Thank you, Lawrence. I've been told that I need to pass the mouse test before I start. There. I guess I'm qualified to give the presentation. I'm a professor at Duke University. I'm in the Department of Biomedical Engineering, and I'm also in global health and pharmacology, which basically means that I'm interested in problems that reflect health disparities. I'm also interested in cancer prevention. And today I'll specifically talk about our efforts in cervical cancer prevention from a diagnostic perspective. So as I mentioned, I direct the center at Duke called the Center for Global Women's Health Technologies. And so, we're very interested in technological innovation for women's health, but I also wanted to just point out that in some of these very low resource communities, sometimes health is often not a priority in these environments when they're energy poor and have really a dearth of resources when it comes to just everyday living. So we're also interested in indirect ways of empowering women so that they can be poised to take care of their health. And so we also do a lot of engineering education and innovation with women in these communities that we're trying to serve through health innovation. So I wanted to start off with a little bit of history. I don't know how many of you know Henrietta Lacks, but presumably many of you know about a book, The Immortal Life of Henrietta Lacks, that talks about social responsibility and really how her cells ended up saving many lives without her consent. But the reason I show her picture here is because she died at a very young age, and I keep meaning to change the date, but she really lived to be 31, not 21, and she had a number of kids, and she did not live to see them because she died of uremic poisoning. But at the same time that she had cervical cancer, there were innovations that have ultimately led to a dramatic decline in the incidence of cervical cancer and the mortality from cervical cancer, as shown in these graphs, in a number of high-income countries. And these innovations are attributed to the Pap smear, which I'm sure many of you know about. This actually is the primary screening modality for cervical cancer in this country, and it really has very high specificity and low sensitivity, so it's well poised to address screening in the general population. And in Germany, while George Papanikolaou was in Greece doing his invention of the Pap smear, Hans Hinselmann in Germany developed the first colposcope. And actually, I believe he tried this out in concentration camps. And what's interesting is it was hard to accept the colposcope as a diagnostic tool following Pap smears because it was very bulky, but ultimately it was accepted and obviously is ubiquitous in places where there are well-organized screening and diagnostic programs. So if you put it all together, it looks like this, right? So the Pap smear is used for screening. The colposcope, which is about as tall as I am, is used for viewing the cervix with acetic acid staining in women with a positive Pap, and a biopsy is taken of suspicious areas to confirm the presence of disease, if there is disease. And then the main way of treating premalignant lesions of the cervix here is using LEAP, where essentially you're scooping out the area. And the rest of I would say up to a depth of about anywhere from, I guess, 5 to 8 millimeters. I was just learning about this depending on the degree of disease, and the idea is essentially just to scoop it out so that the margins are clear. And in low resource environments, I think cryotherapy is more prevalent just because it doesn't need power. So unfortunately, the data is more grim for global cervical cancer incidence and mortality. And really, if you look at the dark red areas, those corresponds to the areas of highest incidence and mortality. And I suppose what's ironic is the age at which women die of cervical cancer is not too different from the age at which Henrietta Lacks died. And that was, almost 70 years ago. So we have a lot of catching up to do. So if you look just globally, if you look at India, South America, many places in South America, Sub-Saharan Africa, the healthcare delivery paradigm is not unlike what it is here today. You have your primary center, you have your district hospital, you have your central hospital, and then you have different levels of care. So in principle, if you have a low resource setting, if you qualify as a low resource setting and you don't have access to a pap smear or HPV, then the way that cervical cancer screening is done is with the naked eye instead of a colposcope, but you essentially use acetic acid. Oftentimes you don't do a biopsy. If you think that the patient needs to be treated, you ideally would do a see and treat, but because cryotherapy systems are not available in these primary care settings, these patients are referred for ideally a treatment at a district hospital or a central hospital. And of course, if the patient has cancer or appears to be suspicious for cancer, then they would be going to a tertiary center. And so this is VIA. It's very straightforward. You have a light source, hopefully you have good vision, and you have vinegar, and that's the solution. So when I was in India, I was in different countries trying to see what are the barriers to cervical cancer screening. So in Tamil Nadu, they've basically rolled out this really expansive screening program across all the districts, and they go out to villages and screen with this mobile screening van. The problem is that the people who screen are really minimally trained, and they use VIA, so there's no quality control, there's no feedback, there's no reporting back, and there's a high false positive rate, which means that there's the women who don't need to be seen are seen, and then there's also a huge attrition because if you have a large number of women that are told that they need to be seen in a referral center, you're likely going to have a large percentage of those women not showing up because of the lack of proximity of these healthcare delivery sites. And then this is an example in Moshi, Tanzania, where in the primary care center they had the bed and a bucket for speculums to be, sterilized, but in bleach, but nothing else. So they don't even have a formalized screening program. So what's in the guidelines does not translate to what's actually happening in reality. And so really we thought about what could we do to empower unskilled or very minimally skilled community health workers to be able to take on screening. We also have a therapeutic project, but I will not speak about it today in the interest of time. So I gave a talk recently where, I was told I need to think about, how we could imagine a new paradigm for cervical cancer screening, and actually the talk was about health disparities locally, but I think it translates to what we could imagine in a low resource setting. The basic idea is and this is not new, the idea is to use telehealth, where you essentially can either virtually tap into the expert, or you can create technologies that allow you to do much of the physical implementation, such that you can do much of the physical implementation at the point where the patient is. So you can bring the mountain to Muhammad, in other words. And so just as is the case here in this country with health disparities, and what the IHI has postulated as a triple aim, you don't want cancers to be lost to follow-up, you don't want unnecessary referrals and biopsies, and you want a low capital investment. So this is the sort of vision we started with and thought about, now how do we tackle this with innovation and technology? So we thought that we needed to really reimagine the colposcope. And if you look at the standard colposcope, it is quite big and quite expensive, and it's really been designed around the speculum, right? Which is speculum, has been pretty much a mainstay, and everything kind of has to be at some distance from the speculum so you're not right up against it when you're doing any kind of intervention or any kind of examination. So in low resource settings where, again, you're trying to mimic the colposcope. There have been innovations around, getting good images without a colposcope. And basically in Moshi, Tanzania at the referral center, I saw the physician use a flashlight and a camera and try to get a good image. And they are really superb at doing this, but it's not a practical implementation for someone at a community health setting where they're screening a lot of patients. So we asked ourselves essentially, what can be done to make it more economical? And then we obviously went around and looked at what the emerging colposcopes look like, and we saw much of the same, the idea that you have the speculum and then you have some device that looks at the cervix from a distance, and the cost, of course, increases as this distance increases. So either you give up on performance or you give up on, in order to minimize cost, you give up on performance. So we had to really go back to history to think about how to reimagine colposcopy. And so, if you go back to history, you see that the father of American gynecology, James Marion Sims, designed the first speculum with gravy spoons. And he did them on slaves. So not a very, not something to be proud of. And another point here is it was invented by a man for a woman. And we asked ourselves, what if you just imagine the speculum didn't exist? What would you do differently? And what we came up with is essentially the idea of not this picture, but this picture, which is a tampon colposcope. So we thought tampons were invented by women. So what if you put everything on the tip of a tampon? Could you change the way you did colposcopy? And it's amazing. When you bring things close up to the cervix, an inch away, as opposed to a foot away, you can tremendously decrease the cost, because much of the cost is borne in this high resolution camera that is used in a traditional colposcope that makes it about $10,000 to $20,000. You can essentially get to a camera that's $50, and if you produce at scale, much, much less, by simply using off-the-shelf LEDs and hobby cameras. So this is essentially sort of a blown up schematic of the pocket colposcope. Now we actually have something that's been designed and manufactured independent by someone who does human-centered design, but this was the first generation device that used a 5-megapixel camera, green and white LEDs, and then an Arduino microcontroller, and it was the size of a large tampon, but nevertheless a tampon. And so you can see it's amazingly different, right? So just that little handle on the colposcope is what the size of our pocket colposcope is. And what's amazing is that, of course, we're doing price estimates, but really I think that's a moving target. But I think we've come down to the point where we think it could be the price of an SLR digital camera, and the resolution is comparable, the contrast is comparable, the distortion is comparable, so you're not losing performance, which was a criterion we were not willing to compromise on. So if you can, the reason I show this table is, we're talking about electrical power budgets in various countries being something that's not a readily available commodity. So if you look at the electrical power budget, it's much, much lower for the pocket colposcope compared to the Leisgang optic, as is the optical power, because you are essentially not touching the cervix, but within the vaginal canal. And if you look at the camera, we can achieve comparable performance with a 5-megapixel CMOS versus an 18-megapixel CMOS. So this graph basically provides the evidence for something that colposcopists would be interested in knowing, which is the resolution. So on top you have the resolution, and in the bottom you have essentially a variety of different colposcopes, including the Apple iPhone 5S, which is not a colposcope, but is used as a colposcope in some places. And I want you to just focus on the purple circle, and I can't see very well, the blue, the green, the diamond. And you can see that at a magnification of 5 on your left, that you get a comparable resolution between 20 and 30 microns, and the diagonal field of view at that magnification for both devices is around 30 millimeters, which is the diameter of the cervix. So you're not compromising on field of view, nor are you compromising on the resolution. And there's a lot more data that's been published in a paper that we wrote, which has all of the other specs. We actually go through a very tight verification testing protocol that basically shows comparable performance between the two devices. So here are shown images from the high-end digital colposcope, a Leisgang optic, the raw pocket colposcope, and then we had to color correct it because we were not able to get raw format images, and so we had to color correct post-imaging, and we're fixing that in our latest generation. But you can see that there's a normal, a low grade, and a high grade. I'm not a colposcopist. I can't tell you, hey, this looks like it's comparable. But if you look at the contrast and the features, you can see that there's really very little distinction between the top row and the bottom row. And we actually went further and tested the concordance by recruiting 8 international physicians to look at all of our images and tell us whether they thought that there was anything different when they reviewed both the high-end and our pocket colposcope in a blinded manner. So this was the study protocol, and since then we have now about 100 image pairs, so this was an early study. And they used a read index essentially to quantify, or at least semi-quantitatively provide justification for why they made the diagnosis that they did, including the quality of the images. And here are the first 6 physicians. We have since recruited 2 more. And as you can see, they represent, they're expert colposcopists from different parts of the world. So these are the countries where we envision these technologies would be used. So it's appropriate that they're the ones reviewing it. And you can see that the concordance is quite high between the pocket colposcope and the Leisgang optic. For really all of these physicians. And the reason that it wasn't 100%, we believe, because we have since gone on to change the study design, is the acetic acid contrast is critical. And when we did the study initially, we applied acetic acid before the conventional colposcope was used, but not before our pocket colposcope was used, which came in second. So we think by simply reapplying, that would change the concordance and improve it, which is in fact the case. And then when we compare to pathology, they both are equally accurate in terms of, in reference to the gold standard. But as we know, colposcopy does not have a high degree of accuracy, but that was not our goal. Our goal was to recapitulate what the colposcope does and bring it to the point of care. So improving specificity is sort of the one area that we need to focus on, because if we do wanted to give it to a community health worker and there wasn't an expert physician at a virtual remote site that could review it and make a decision there, we would need other ways to bolster that. So physicians here use the green filter to look at the vascular contrast because that's associated with high-grade disease. And so we thought, why not exploit that contrast, since we are well-versed in biomedical optics and could do some tricks to enhance contrast. And so we had done an early study a number of years ago where we used spectroscopy to look at normal, low-grade, and high-grade cervices in vivo to look at essentially hemoglobin concentration, which is what gives us the optical contrast, or the colposcopist optical contrast to look at the vessels. But we went a step further. We quantified the concentration of hemoglobin, and then we also quantified the microvessel density shown on top using immunohistochemistry. And you see representative microvessel density images as well as our extracted hemoglobin absorption, which increases as you go from normal to low grade to high grade, but we can also get concentrations in addition to looking at these absorption curves. And what was important about our spectroscopy technique is that we're able to use models to decouple scattering from absorption, which can make the nonlinear effects of scattering. And so by removing those effects of scattering, you actually get absorption that's linearly related to concentration, which then gives you this underlying information. The problem with spectroscopy is it's a point probe. It's not doesn't give you spatial information. So we then went on using the information that we had to design a dark field microscope, and now we have a clinical version of this that we can actually start to use in patients that allows us to look at microscopic vessel contrast that gives rise to those changes in hemoglobin concentration. What we did here is a hamster cheek pouch model study. I know there's nothing in common between the hamster and a woman, except for the fact that the cervix has squamous epithelium, much like the hamster cheek pouch, and the hamster cheek pouch model can be painted with a carcinogen to basically provide the whole dysplasia carcinoma sequence that we can then image for the changes in vascular contrast that are similar to what you would see in cervical dysplasia. And so here I show essentially at 3 distinct wavelengths the contrast from vessels in normal, dysplasia, and SCC, squamous cell carcinoma. And you might notice 2 things. One is if you look at a single wavelength and look across, you see that the vessels become more and more tortuous. But also what's interesting is as you go to longer wavelengths, you start to see deeper vessels, particularly when you go down the SCC column. At the very top, you see these very tortuous spider-like vessels, but as you go to the bottom, you start to see the bigger vessels. So we thought, why not use this wavelength dependence to capture different depths and capture both the large and the small vessels and look at the potential contrast and sensitivity and specificity that this might provide. And so what we did first is we obviously took these images and we created masks and validated these masks. And once we got these Gabor masks, we actually merged the different wavelengths so that we could essentially compile all of the vessels and then look for contrast by vessel diameter. And so in the remaining, 3 minutes, I guess I'm going to just speed up a little bit here. What we did is we essentially broke down the data into large vessels and small vessels, and then we looked at quantitative endpoints because we're very quantitative in how we approach our methods. We want to be able to relate this back to the biology. So we looked at tortuosity, diameter, and area fraction. Tortuosity is used widely when you're thinking about angiogenesis and doing research with the vascular physiology. And we found that tortuosity went up, but diameter went down, and the area fraction went down. But when we looked at the small vessels, we actually saw that tortuosity still went up, but the area fraction and the diameter went up. So you could have imagined that if you had sort of just bundled them all together, you might have washed out some of the contrast that you see here. And then we use standard logistic regression models to essentially calculate performance. And then here is the ROC curve for large and small vessels. And you can see that for both normal and SCC, as well as normal versus dysplasia, you have excellent area under the curves for this approach. So the point here is that we start off with creating a platform that is equivalent to what colposcopists use, and we're hoping to actually get this to implementation in Peru in the next year. And what we're then hoping to do is use that platform to then add in additional features that could allow for less and less training and wider scale implementation in places that need it the most. So just a summary of the points that I was trying to make in this talk. The first is was that we rethought the implementation of the traditional colposcope to a tampon configuration to enable low-cost innovation with comparable performance. And it really did take a new way of thinking about how things are done. And we've also now, since this innovation, developed an inserter that is self-insertable, so women can actually see their own cervix. And we've actually tested this out on 20 volunteers, and we're hoping to do a study in Peru, especially in places where, again, it's intuitive and you can do it yourself versus having a male provider do it for you. The other is that the vascular contrast needed to be decoupled from scattering to truly see how it's enhanced in severe dysplasia. And once we knew that, there was this contrast, we wanted to go deeper and we wanted to see what the spatial information looks like. And so we developed multi-wavelength dark field microscopy so we could unravel the vessel contrast at different depths and then compile them and see where the contrast lies. And we're excited that actually our tampon colposcope can be rejigged to do dark field microscopy, or at least something comparable. So we're going to use the same device, but at a higher resolution to zoom in and get additional information that you would otherwise not get as easily with a emerging or traditional colposcope that isn't the highest end colposcope on the market. So with that, I'd like to just close by saying that, whenever I have problems in the lab or with this technology or clinical studies in the field, I keep coming back to this truck stop on Kandui Road in Kenya, between where the trucks come and where much of the prostitution occurs. There is this place called the One Stop Wellness Center where women come in for HIV testing and cervical cancer screening. Of course, there's really no cervical cancer screening, but the idea is that we can bring technologies to these outposts and people will come. I'd like to acknowledge our multicultural, very diverse group of collaborators from all over the world. I don't have time to name them independently, but I think it's important to point out that this is what makes this intellectual exercise a really fun social activity. I'd like to also acknowledge the many wonderful students and staff members that are working on this particular project in my group, and I'd like to acknowledge funding from the NIH and Duke. Thank you. Questions?
Yeah, we have time for questions.
Hi, thank you so much. I was just wondering if you could comment on your experience or advice on how to address like the tactfulness of really discovering what the problems that they face in low resource settings are and how to get a handle on what you might be able to do to help fix that.
I found that the best way for me is to find a champion on the ground. I actually have to say that we've had more bad luck than good luck. And it's because we feel sometimes that we are the ones with the passion. And I think finally in Peru, for example, as an example, we found somebody who is almost ready to give up his day job to solve cervical cancer challenges in his country. And he was just here yesterday and kept insisting that we meet for 12 hours instead of 8. And that's the kind of person you want, who is impatient. And I think you just have to, it's trial and error. And we've been to so many countries, and finally we got lucky. That was it for me. I'm sure it varies.
Thank you so much.
How close do you think you are to like commercializing and getting it out there?
So that's a really good question. Probably, I don't know if I have enough time to talk about it. I think I need more advice on that one. But we actually are getting a beta device in October. We actually work on our grant with a designer and manufacturer who does global health design, an incredible person. So we've gone through the whole process, gotten user feedback, and come up with a really nifty, and I wish I'd shown it here, but it's blue and white, Duke blue and white, and everything's on the colposcope, so you don't have to press a button anywhere. It's hooked up to a cell phone, and all you do is, you've got green light, white light, low magnification, high magnification, low light levels, high light levels, everything basically, something that your thumb and your finger can do. And it's ready. I mean, we already have the alpha, and the beta is ready to go. The harder part is figuring out the business model, and we have a grant now to specifically work on a global value chain analysis where we can see what the bottlenecks are, what the opportunities are. And our effort is really to think about how we might do this from Duke. How can we do a lot of the innovation and the technology transfer and the commercialization pieces, or at least de-risk much of it within Duke, so that we could talk to a Philips or another entity that would be really interested in addressing this emerging market.
Final quick question.
Can you ever envision bringing radiation therapy to these third world countries?
I'm not the person to answer that question. I will tell you, though, that I didn't include in my talk something that we're doing that, again, my Peruvian colleague is very excited about. I would say that my experience with cervical cancer prevention has been in places where they're marginalized communities that are not getting access to cervical cancer. So even, the question is, if there's a sex worker or an MSM population, not cervical cancer, but anal cancer, these are people that are not getting access to therapy. So I don't know about getting radiotherapy to those people, but those are the people that motivate me to work on solutions. So we've actually figured out, nothing new, ethanol ablation as a potential solution. But the problem is ethanol ablation has worked really well in hepatocellular carcinoma, which is essentially very capsular, but cervical precancer, premalignant lesions are not. So we figured out how to create essentially encapsulation of the ethanol within tissue so that we can essentially inject it. It gets into the tissue within a certain, and has a certain distribution volume. It stays there so that it doesn't leak into the vasculature. We can also prevent it cracking the tissue and leaking out from the tissue. And we can also lower the dose of ethanol so that there's very low systemic toxicity. And in our preclinical studies, that has worked phenomenally. And that's what we're hoping will be useful for premalignant lesions. Cancer is a different story. That's where radiotherapy comes in. And I think my colleagues will tell you much more than I can.
Thank you very much.
Sure.